Hello everyone, let's welcome to Prosthodontics. That's the first topic that we will take today is Introduction to Prosthodontics. Coming up to definition, what exactly this brand says. Prosthodontics basically means missing replacement. A very vague but a small terminology is replacement of whatever is missing. What can be missing? Our teeth can be missing. Any maxillofacial structures can be missing. For example, our ears, our nose, our eyes, our face, or any obturators. Basically, it is the replacement of any missing tooth structure. And what are prosthetics? That is the thing by which we are going to replace the missing structure will be known as the prosthetics. Coming to branches of prosthodontics. Widely, prosthodontics is divided into basic two branches. It can be either fixed prosthodontics or it can be either removable prosthodontics. Now, removable prosthodontics that patient can remove by himself or herself. Fixed prosthodontics is that which a patient cannot remove and it is fixed with the help of the dentist or professionals. So, in removable prosthodontics, that is further classified into complete dentures. It can be removable partial dentures. It can be implant supported over dentures. So the next is the fixed prosthodontics. So in fixed prosthodontics, we have the crowns, the bridges, that is also known as the fixed partial dentures. We will have implant supported fixed partial dentures, that can also be a fixed prosthodontics. Coming up to maxillofacial prosthesis, that is a branch again widely which can be further classified into removable as well as a fixed prosthodontics. How is that so? Now maxillofacial prosthesis, for example, our nose, our ears, now when we are replacing it and we are not fixing it with an implant, so that will be under removable prosthodontics. If we are fixing it back, then that will be under fixed prosthodontics. Coming up to diagnosis, treatment planning of complete edentulous patients. First and foremost thing is examination of the patient. Why is that important and how much is that important? Why do we need to take a case history? In oral medicine, we have learned so many case histories, formats, but why do we need? We need to know the case history, one, to know our patient well, to get our interaction with the patients, to know the medical histories of the patient so that we undergo the complications which can come up. We already know what can come up to us. To come up to the definition, examination is defined as the scrutiny or investigation for the purpose of making a diagnostic or an assessment. So what are the things that you need to note down in a case history or introducing yourself to the patient? First, knowing the name, and how is that helpful to us? The first thing, name, gives a psychological effect. When I call my patient with a name, the patient feels that the doctor is so much close to us. Secondly, important is maintaining the data. The next is the age of the patient. How is the age matter to a prosthodontist? A prosthodontist should know the age because most of the patients that come to us will be a complete edentulous patients of age more above 50 years. So the age-related disorders in those particular patients are important for us to know and anticipate before, even if the patient is not saying us. A patient coming to you might not know that he has a sugar. So you need to know that if a patient is above 50 years of age, the blood sugar level can be high in those particular patients. There can be a problem of hypertension. Even if the patient doesn't know, you can send the patient for the further investigation to a doctor. Similarly, sex is important. How is the sex important? The gender is important to us because there are many diseases, many kind of coming up diseases which is related to the sex of the particular patient. For example, in a male, the males are more prone towards the diabetic particular thing, whereas a female is more prone towards the osteoporosis, that is in the age above 50, when the menstrual cycle is going to stop. So the calcium level in that particular age, if the body is not having enough calcium level, then that patient's healing after your surgeries are going to be compromised. So you need to know certain sex of the particular patient. Coming up to the occupation, how is an occupation important to us? First and foremost thing, occupation is important to know certain occupational hazards that can be caused because of their particular profession. For example, a tailor coming to you can be totally anticipated of an attrition because he will be keeping his needles all the time in front of his central incisors. So you can always anticipate a attrition in those kind of patients. So occupation in this way is going to help us to know how was the lifestyle of the particular patient. so that you can do your treatment plan according to that. Coming up to race, like Indian race or ethnic race or the race where you come across a overseas patient. So in those kind of races also we do have different treatment. For example, the teeth that you're going to give for an Indian patient will not be a white teeth. It should be somewhere near to pale yellow to whiter teeth. Whereas a patient coming from US, you should be giving a teeth which is more complex to his body complexion. That is, he is more fairer. So the teeth that he deserves is also more fairer. Coming to chief complaint, a very important thing to note in chief complaint is let that be in the patient's word. Whatever is patient saying, let that be followed by you. It is not your complaint. It is the chief complaint of the patient which he is delivering to you. So the first and foremost thing of a dentist to work on as a chief complaint is that you need to treat the chief complaint and then go forward for other parts of the treatments. Next is, what are the patients that questions that you need to ask your patients? The questions that you need to ask is, how much time does he is edentulous of? How much time before did he extract his teeth? Was there any problem during extraction of any teeth? Why is he come for the dental treatment? It can be either because he cannot chew. It can be either because of his cosmetic appearance. So what is the patient's requirement from a dentist is most important for a dentist to know. Coming of history of present illness, that is what you need to anticipate the further prognosis. What is prognosis? Prognosis is the relevant treatment outcome that you will give after your treatment. So, what expectation the patient has from you? That is another important thing. If the patient is cosmetically concerned, aesthetically concerned, your treatment plan should vary accordingly. If the patient is more concerned about chewing and mastication, like in case of males, they are more concerned about mastication. It should be enough to chew. For a female patient, you cannot give a unaesthetic teeth. They are more concerned about aesthetics. So that is how you need to know the expectations of the patient. Coming up to the mental attitude of a patient. There can be different types of patients that come down to our clinic, our hospitals. We need to assess the patient which has come because every patient is different. And you need to also know that what patient is expecting. So while you are taking in these histories from the patient, you need to start assessing that how is the patient and what he is going to treat you like, the patient is going to treat you like. So classified by House, sir, into 4 categories. There is philosophical, exacting, indifferent and hysterical. What does philosophical patient means? A philosophical patient is all in your hands. That is the patient which is totally in belief of the dentist. He has no issues. Whatever you say, he will accept that. He will believe on you. Rather, he will cut down his own busy schedule and will be coming up to you according to what you have scheduled to the patient. But exacting kind of patient, they are a little difficult to tackle with. How are exacting different from philosophical? Almost all the characteristics, like they are good, they believe in dentist, is everything fine. But the only thing differs from philosophical to exacting is exacting kind of patients do require more care. That is, you need to give some more time to those kind of patients to make you comfortable to the patient. And once the patient is comfortable to you and believes in you, he is the best supporter as a dentist to the patient. Coming to indifferent kind of patient, as the name already suggests, they are indifferent. We cannot suggest, we cannot anticipate what they are going to think. We cannot deal with what their psychology is. What we can do is, we need to treat them with ultimate care, and that is where it is going to support the particular patient. But then how to treat with these kind of patients? To tackle with these kind of patients, we need to be very calm, very patient. We need to explain every step of your procedure to make that patient on your support. So the next kind of patients are the hysterical kind of patients. How does and what does that kind of patient certify us? Hysterical are the patients are those otherwise known as skeptical according to Oxford Dictionary. What does that mean? These patients are going to doubt you from starting to the end and cannot be satisfied by whatever hook and crook treatment plans or your care you do. These are the patients who do not believe in they do not have any respect for the treatment. They are sent by their relatives So they do come to your clinic because of the pressure from the house, but they do not believe you. There will be questions for every step. There will be questions for every kind of treatment plan that you are going to give to the patient. And then they will not be satisfied. The prognosis for these kind of patients are really very poor. So that is one kind of patient that we should be aware and worried about. Coming to the medical history, most important thing as a dentist that we need to know is the medical history. What is the blood sugar level of the patient? What is the blood pressure of the patient? What are the medications the patients are undergoing? Is there an allergy to the patient from any other medication or any other food or lifestyle that he is undergoing? That may be allergy of silver amalgam, there may be allergy of local anesthesia, the adrenaline that we are giving. So there can be allergies to various things that we need to know from the patient, and also there can be other diseases which are very heart-throbbing, like there can be a cancer, there can be any other AIDS or any other immunosuppressor diseases that we need to ask the particular patients. Coming to dental history. Again, in dental history, everything relates to the chief complaint that the patient is giving. So dental history, how is that important? Yes, because the last time when the patient had visited any dentist overbeen, had he had got any complication? Had he suffered from any kind of problem due to the medication that dentist had given? Was there any complication related to any procedure that the dentist had carried over? So that is like a question mark to you. That is like a precaution that you need to take from that particular history. One more important thing regarding dental history is you need to know and ask the patient is how long was those teeth out from his mouth, or basically the edentulous period of that particular patient, and also was the reason for the edentulism. That is, if the patient have lost their teeth because of caries, so that is not very difficult problem for us or difficult for us to determine the prognosis. But if the patient is lost because of periodontitis, so that means the bone is not enough to support the particular teeth. So then you can totally and 100% expect there is a resorption which is going to happen in further years after your treatment plan that you're going to give. So you need to be even caring about that particular thing. Clinical evaluation, extraoral examination. Coming to facial form, how we decide the facial form of the particular patient. So Hausen-Lou, Fisher, Williams, everybody came up to different things, and finally we have now decided 3 basic points to decide the facial form. So the first point is the bizygomatic point here. Second point is over here, that is bitemporal points, and the third point is the bigonial points. So once you match these 3 points, then you will find out whether the patient is square, ovoid, tapering, or a combination of square tapering. Facial profile that was given by Angle, the father of orthodontics, he said to measure the facial profile, take 3 points. That is, 1 is the point over here, clavula, second, the subnasal, and the highest point on the chin. So if you match these 3 points, then again you will find out the facial profile, whether it is normal, prognathic, or retrognathic. Complexion of the patient, important for us as a prosthodontist very much, because to determine the teeth, to determine the gingiva color that we are going to give in the dentures or even in the fixed prosthetics. Coming to lip support. Lip support is adequate or it is lost. How will that be decided? That is decided based on the age, tenosity of the particular muscles. Because if the lip support is not there, you need to make the dentures little prognathic. If the lip support is too much, you have to keep the denture and the teeth little retrognathic. Similarly, lip thickness. Already if the lips are thick, so we cannot afford to give a anteriorly placed incisors. Whereas a lip length, how do we measure lip length? Lip length is measured from subnasal to the base of the vermilion border. So if lip length is more and the ridge height is less, if the lip length is more and the ridge height is less, so you need to give long incisors so that those are seen from the visibility from the front of the patient. Whereas the opposite, if the lip length is small and the patient has, then what will come up to? It will come up to a gummy smile. Then the gingiva will be taken over the teeth. So you need to keep records about the lip length. Coming to lip fullness. Lip fullness. How is lip fullness important to us? This area where is the ala of the nose ending out, and this particular area where we have the ala of the nose coming to an end, this particular, if it is not supported, it will be sunken down. Once the sunken down effect comes to a denture, it doesn't give a very aesthetic appeal. So you need to know about the lip fullness of the particular patient. Lip mobility, that is totally dependent on the patient. And how is that classified into normal, class 1, class 2 is reduced mobility, and class 3 is totally paralyzed, where you cannot help anything out with. The muscle tone, again the muscle tone is based on the age of the patient, is based on the skin texture, tonicity of the patient. If the muscle tone is normal with tone and function, that is class 1. If the function is fine, tonicity is lost, that is class 2. Class 3 is when tonicity, function and everything is lost, that is the neuromuscular coordination of the patient is totally lost, that is class 3. Examination of the temporomandibular joint. We have all known till now that the temporomandibular joint is a very important part for our dentistry. And so examination is important because to follow a further treatment, you need to know if your jaws are supported well, if there is any clicking or crepitus sounds present, if there is any ankylosis which is present, if there is any other surgeries which is present, is there any deviation and deflection in particular patient, so that you can be aware of the particular treatment that you're going to be providing to the patient. Neuromuscular evaluation, the speech and coordination. Is the proper speech there? Is the muscular coordination what you are speaking, is the patient able to understand? If not, you are very much important to notify the patient to get his or her relative next time for the next appointment, so that the things are well explained and can be well coordinated with the patient to be aware in the further appointments. Coming up to intraoral examination. Now we are entering into the oral cavity of the particular patient. So what all we are supposed to see to anticipate our prognosis? The first thing that we are now supposed to see is the arch size. Class 1. The arch size is large, is big. That is, the maxillary arch size is supposedly to be thought of 24 centimeters square. The mandibular arch size is thought to be something around 14 centimeters square, 12.8 to 14 centimeters square. So we need to anticipate that how big is the arch size. There can be at times the maxillary arch is bigger, mandibular arch is smaller, or the maxillary arch is smaller and the mandibular arch is bigger, which is the maximum time you can see. So these kind of patients, you need to anticipate from the arch size that how the resorption pattern has happened. Generally what happens, the maxilla size grows lesser in size and mandible expands in its size. So we need to even watch for that. Arch form of the patient. Now arch form is how is the arrangement of the teeth inside the arch. Is it squarely arranged? Is it taperingly arranged, or is it ovoidly arranged? How is that going to help us? If it is squarely arranged, that means the lip fullness is going to be there. That is supported by the teeth itself. If that is tapering, that means there will be already sunken borders in the corner of the lip. Whereas ovoid has not much importance with our planning of the complete dentures. Residual ridge contour. It is very important for a completely edentulous patient to understand that how is their residual ridge left out when the patient enters your dental clinic. So for maxillary arch, the upper arch that you have seen is, it can be the U shape, it can be V shape, or it can be totally flat. Why is that so? Because any bone resorbs to centrifugal or centripetal. Coming to the maxillary, it goes centrifugal. Coming to the mandible, it comes to centripetal. So next is the mandibular ridge form that you're going to see. Again, in mandibular ridge form, you have the same kind. It can be the U, it can be V, it can be W, it can be inverted W, it can be sharp knife edge. Atwood in the book of Carl Misch has very nicely explained the order of residual ridge resorption into 5 orders. That is order 1, order 2, order 3, order 4 and order 5. It says from the time of pre-extraction to that of a flat ridge, there are different change of architectures which happen in the bone. Now what matters is in which architecture the patient is coming down to you and your clinic for the treatment. So that is again going to modify your treatment plan. Coming to ridge parallelism. What is ridge parallelism? So ridge parallelism can be classified into class 1, class 2 and class 3. What is that based on? So what are we going to take as constant? The constant thing that we will take is the occlusal plane. From the occlusal plane, the mandible relation is what we are going to classify this accordingly. So if the mandible to the occlusal plane is parallel, class 1. If the mandible is diverting anteriorly, it is class 2. If mandible as well as the maxilla, both the arches are diverting from the occlusal plane, that is again class 3 kind of ridge parallelism. How will we watch and anticipate for the ridge parallelism? We are supposed to take the study models and then mount it in an articulator to find out the parallelism of the ridge. The another way to find out ridge parallelism intraorally is ask the patient to be steady, relax himself, speak a word which is bilabial like ma. So then when the patient speaks this word continuously, he gets into a relaxed position, a neuromuscular relaxed position. So in that particular position, part the lips properly and then you can find out about the ridge parallelism. The same way you are supposed to find out about the ridge relation, and also that can be done intraorally. Next is intermaxillary space. Now coming to intermaxillary space is the space between the maxilla and that of the mandible. So what is the space which is ideal? The 20 mm space between the two incisors are the ideal amount of space. Okay. So anything which is less than that will be less, anything more than that will be excessive. What will happen if we have less amount of intermaxillary space? So if we have less amount of intermaxillary space, the teeth that we are going to give in a complete dentures will be again smaller in size. We will have less space to manipulate. Whereas the intermaxillary space, if it is more, then we have to give bigger teeth. So that will cause instability to the denture. Coming to mucosa, how is the mucosa of the particular patient is another important thing that you need to understand and investigate before you start your treatment. So mucosa of the patient, if it is flabby, then it is again bad. Why do flabby mucosa come? Flabby mucosa, or why do reductant tissues develop? Because of the body mechanism. So then comes to the hard palate. Then hard palate, how is it? Either hard palate can be straight, it can be U-shaped, it can have a deep vault. So if the patient has a deep vault hard palate, then it is again difficult for the denture to be stabilized. If the patient has a hard palate which is straight, again that is difficult for us to give stability to the denture. So next comes is the position of the patient. So once you are starting your treatment plan, you need to understand what is the position of the patient, position of the operator. When you are operating in the maxillary arch, when you are operating for the maxillary arch, you stand either behind the patient or in an 11 o'clock position of the patient. Whereas if you are doing it for the mandibular arch, stand in front of the patient. The front position to the patient is better for a mandibular arch. Coming to the soft palate. The soft palate, how is the soft palate examined? So soft palate, you ask the patient to look down. That will give you, this position will give you 30 degrees to the Frankfurt horizontal plane. So in this particular position, what happens? It is the most depressed position where the soft palate we can examine. So that time, if the soft palate is straight, that is class 1. If it is very acute, that is class 3. And anything between class 1 and class 3 will be class 2 soft palate. Coming to tongue. Tongue is classified by Wright, is classified by Hauser in different positions. The main thing that we need to look into tongue classifications are, is the tongue adequately placed in between the teeth? Has the tongue come over the ridge? Has it been a broader? Is it a narrow and longer? Why is that important? Now if a tongue which is coming over the ridge, that means the denture that we are going to give to the particular patient is being disturbed by the tongue all the time. If the patient has a habit of a long and narrow tongue, he will dislodge the denture anteriorly. If the patient has a tongue which has retracted tongue, the denture seating will be a problem. So examination of a tongue is very important. Coming to saliva, another important thing which rules our oral cavity is saliva. So class 1, normal quantity and quality of the saliva. If there is excessive saliva which contains mucus saliva, that is present, And class 3 is xerostomia, where there is less amount of saliva. So the class 2 is also known as stylism patients. So the next is floor of the mouth. So how will you inspect the floor of the mouth, and how is that important? That is important to develop a complete denture, because the complete denture flanges will be determined, the height of the flanges will be determined how depth is our floor of the mouth. So we need to inspect the floor of the mouth. How will we inspect the floor of the mouth? We will do it with a mouth mirror or with the indexed glove in an index finger. So next comes as a lateral throat form. Now another important thing which was given by Sir Neil Sir was lateral throat form. What exactly it is? It is the posterior part of the retromylohyoid fossa with the floor of the mouth. So how will we inspect that? We will inspect that with the help of our index finger or with the help of our mouth mirror. If we are dipping the mouth mirror along with the mylohyoid ridge below the floor of the mouth, and the floor of the mouth is getting adjusted to how much ever you are dipping it down with your finger or your mouth mirror probe, I mean it is not giving a negative pressure back. I repeat, that means if the place for the space for your index finger and space for your mouth mirror is enough to accommodate below the retromylohyoid fossa along with the sides of the mylohyoid ridge, that is class 1. Let's see the diagram. This is how it is if there is more space. For class 2, you need to see if they have a little pressure from the floor of the mouth when you dip your index finger, but not much that it is lifting back there is no space. Whereas a class 3, when you will dip your finger or your mouth mirror, it will just lift it back. That means there is no particular place for your denture flanges. So that will decide that how much area is beneath your mylohyoid ridge to get retention to the particular denture. Coming to tori. We all know that tori can be possibly there in everybody's mouth. What is important to know is that tori pathological or philosophical? Physiological. So we need to know if the tori is going to be harmful to us or the tori is fine while preparing our dentures. So class 1 tori is absent, totally is not there. Class 2 tori is of moderate size. Those tori of moderate size can be thought of keeping it in their particular place. Class 3 tori is a large tori which you need to go ahead with pre-prosthetic surgeries before starting your treatment planning. Coming to frenum attachments. Now frenum is there in both maxillary as well as mandibular arch. Now what is important to us is that frenum is there which is encroaching on the borders or on the crest of the ridge is harmful to us. Any frenum which is coming crest of the ridge, that means the denture cannot be supported over there. The denture cannot be seated in that particular place. So frenal attachment is classified again into class 1, class 2 and class 3. Class 3 is the frenal attachment on the ridge. Now why will a frenum come on to ridge? Either the ridge has subsided down because of resorption, either the frenum itself is grown till that particular position, or these can be also thought to be corrected surgically before starting up any treatment planning. Coming to diagnosis, a very beautiful definition given is diagnosis is determination of the nature of the disease. Our Sir Hartwell said the definition to be a little more longer, saying determination of the nature, location and cause of the disease. So to understand what this disease is gonna be, how is the disease gonna end to us, any edentulism is also a disease for a prosthodontist. So you need to, how will you decide the diagnosis? How will you go ahead with the diagnosis? You will take a pre-extraction records, you will have your radiographs with you, you will have your diagnostic cast. The beautiful thing another which you can have is the old pictures of your patient, how the patient's teeth were earlier. Sometimes the patient desires to have the teeth which he already had. So you need to have the earlier photographs or life-size photographs to know what was the patient's earlier teeth. Coming to prognosis, as I was saying you, prognosis is nothing but it is the end of anything. It is the end result. It is the outcome of particular treatment that you are giving. So give the prognosis and list the regions of the prognosis. As in, once you have taken out your case history, now you know if the resorption is going to happen, what are the medical histories present, how is the characteristic behavior of the patient towards the dentist, Now you know what are the arch size, what is the intra-arch space, you know what is the lateral throat form. When you are evaluating all these things, now you can distribute your prognosis according to that, and you can tell the patient beforehand that you do not expect a good result out of this, or we will try our best and give best. So prognosis is classified into three types. It can be excellent, it can be fair, or it can be very poor, and that will all depend on the case histories that we have taken. So the basic motto of a case history is just not to know the patient, also to find out what will be the final outcome of the particular treatment that you're giving. So this is what ends the introduction and diagnosis and treatment planning to complete NGS.